Start right now.
Yes, good afternoon, everyone. I'm Cha from International Cooperation Department. Today, I'm very happy to be here to introduce the participant from the University side. Firstly, I want to introduce the moderator, Dr. Lê Nhật Huy.
Good afternoon.
The speaker, Dr. Lại Thanh Tùng.
Good afternoon.
Good afternoon.
Good afternoon.
And Dr. Thao. Thank you.
I'm Dr. Liu from VGH Taiwan, Cultural VGH Taiwan. My left hand is Dr. Zhang. Our CI is Chip, and my front desk is Dr. Huang, radiologist, department section chief. We are ready.
Yes.
Anh giới thiệu Tùng.
Okay. Let me begin.
Yes, sure.
Yes. Good afternoon, ladies and gentlemen. First of all, I would like to introduce myself. My name is Lại Thanh Tùng. I'm doctor of oncology department, Việt Đức University Hospital. I'm very delighted to be here to present about management for colorectal liver metastasis. My presentation is divided into two parts. Firstly, about introduction of colorectal liver metastasis, and secondly, I have two key results. Colorectal cancer is one of the most common cancer in the world. It's accounting for 10% of all cancer cases worldwide, according to Global 2020. And liver metastasis is most common sign of distant spread. There are two definitions here need to be understood. The first one is synchronous, and the second one is metachronous. Synchronous is in which the patient will have distant metastasis at the time of primary diagnosis. Is accounting for approximately 15 to 25% of colorectal cancer, and metachronous include two types. Early metachronous are considered to be those detected within 12 months after diagnosis or surgery of the primary, and late metachronous are considered to be those detected more than 12 months after the diagnosis of the surgery of the primary. Several studies have shown 5-year overall survival rate of 47 to 60% after hepatectomy for colorectal metastasis. So that hepatectomy ability is very important in management for colorectal liver metastasis. The next slide. Here you can see the treatment option for colorectal liver metastasis, and the hepatic resection remain one of the major curative treatment options available to patients with liver metastasis. In some case of difficult hepatic resection with tumor less than 3 centimeters, radio frequency ablation is also very important in the treatment. And decision making for these patients can be complex, and several factors must be considered. There are 4 main factors to consider before deciding on preset ability of the colorectal liver metastasis. The first is oncological appropriateness, and the second is sufficient remaining liver volume, including quality of liver parenchyma. And the third is the reception machine, and the finally is technical feasibility. So it's hard to decide how and when we do surgery. This is a clinical risk score of form in 1999. Multivariate predictor of recurrence is a positive machine. Is extrahepatic disease is bigger than 1 tumor. CEA is bigger than 2,200, and tumor is bigger than 5 centimeters, and disease-free interval is less than 12 months. And see the tablet 5, the 5-year Icarian survival rate for patients with 0 point was 60%, whereas that for patients with 5 points were 14%. This is a criteria of the resetability before the criteria is limited, but nowadays is so extended. As you can see the comparison. As you can see the comparison. Nowadays there is no limited about size and number of tumor because we have neoadjuvant, we have after surgery, we have radio frequency, prison resectable extrahepatic metastasis, and safe resection machine are still a goal of therapy, and a minimal surgical clearance machine of 1 millimeter has been successful at substance. And in scale of synchronous, we can perform hepatectomy and colectomy at the same time if qualify as a surgeon adjustment and anesthesia rescue situation. And we can use 2 techniques to increase liver volume, like right portal vein embolization or right hepatic vein embolization. See, this is associating liver partition with portal vein ligation for state hepatectomy. In step 1, we do tumor resection for the running liver and ligation of the right portal vein or right portal vein embolization after to increase the liver volume. After 1 or 2 weeks, we do resection of the can you hear me?
Yes, we can hear you.
Yes. I'll continue. And liver transplantation is also one option for colorectal liver metastasis from 2013. And now it's a second part is the 2 reports. The first report is left colectomy and radiofrequency metastatic liver tumor. Male, 41 years old, and he has left colon cancer and 1 tumor in dry left liver. The size is 36 millimeter, and the patient got a neoadjuvant cell 5 circle, and after that, partial response to reduce 44%. And now the size of tumor in liver is 21 millimeter. You see, we do perform left colectomy and radio frequency metastasis liver tumor in assuming age. Yeah. And the next is the second favorite spot, liver, lung, peritoneum, and ovarian metastasis from left colon cancer. You see, this is the summary of the poor treatment is very complicated. The female, 62 years old, in July 2017, the patient had left colon cancer, and we did left colectomy, lymph node resection D3, and Douglas peritoneal resection, and his pathology is adenocarcinoma PT4A and 1, and lymph nodes metastasis 16B2 M1 peritoneal metastasis in porch of Douglas, only one less than 1 centimeter. No machine well different, Raspberry and PD1 negative. After that, the patient got adjuvant chemotherapy, cetuximab with the trial circle in August 1918. 13 months after operation, we found liver metastasis in segment H. Size is less than 3 centimeters, positive in PET CT, and with radio frequency. The patient continued to get adjuvant chemotherapy, modified FOLFOX6 and bevacizumab with 6 circle, and then this process was disconnected because she was so tired. We moved to capecitabine and bevacizumab until January 2019. After that, the patient received AEIT, autologous enhancement immunological therapy at Hanoi Medical University. Yes, in 2019, 22 months after operation, we found lung metastasis, found in both sides of the lung. The size was 5 to 7 millimeter. Later, we use chemotherapy with modified FOLFOX6, bevacizumab, 5 cycle, and she has stopped for fatigue in March 2020. For 32 months after operation, the patient get progress easy by increase the number and the size of lesion of the lung, and lesion of liver is stable. She get FOLFIRI bevacizumab twice cycle until September 2020. You see the CT of patient. 2020 lesson in the lung and liver, and the lesson in segment F is stable, and here is lesson in lung, right? Lung, and then she had a new lesson at ovary. More than 3 years after operation, and we found lesion at ovary and both sides, and then we decided to re-operate in December 2020. We do second look. He raised to me and offered to me no peritoneal and lymph node metastasis, and his pathological result is adenocarcinoma metastasis from colon cancer, and then she get chemotherapy by FOLFIRI and cetuximab, trial circle, and then we maintain capacity 12 months. And it's July 2021. She's stable, and here is a lesson in segment X. But in December 2021, the lesson of segment X and lung is progress easy, and we do perform radio frequency in January 2022 and June 2022 in segment S, and then we maintain capacity. You see, it's the lesson of lab. This and this here, 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 and here. And the lesson is segment S is the liver. It's bigger than we do radio frequency twice. The first is in January 2022, and the second we do radio frequency in June 2022, and now she's stable, equal one, and we maintain capacity until now. Thank you. Yeah, now if you have any questions, please do not hesitate to raise. And also my English is not quite good, so Dr. Cha will happy to translate my answer. Yeah. Thank you for listening.
Thank you for your excellent talk. I think your treatment, your management, and your thinking process is very standard and very aggressive. We would like to listen about some comment from our doctor surgeon, Dr. Zhang and Dr. Fang.
Thank you for your excellent presentation, and did have done a lot of procedure for the patient and keep the patient alive till now. And I look at the treatment course. I have two suggestions or comment for the treatment. The first one is that at the first time of lung metastasis, there were 4 metastatic nodules. It's small, less than 1 centimeter. I think that lung RFA may be done at that time to remove the lung nodules. I think we may give the patient a systemic therapy and such as systemic therapy, such as the target therapy and the chemotherapy. And the plus we can also do the local treatment for the patient. In this patient, the lung nodules is suitable for RFA. So this is the first suggestion, I think. And the second is about the chemotherapy or targeted therapy. And according to the NCCN guidelines, you have given the patient about bevacizumab and plus chemotherapy or Erbitux plus chemotherapy. But the disease is progression. So the next line chemotherapy, I think Stivarga plus with or without chemotherapy may be considered for the third line therapy, or no serve, a kind of chemotherapy. Or another name is class 1 or 2. This chemotherapy may, with or without targeted therapy, also suggested to the following and next stage treatment. I think not just oral compensating. Thank you.
Thank you, Dr. Zhang. Very clear comment and suggest. How about our Dr. Huang?
I'm going to regard this. Yes, we have many experience in tumor operation of liver metastasis or lung metastasis. Usually, we do it in CT scan for liver operation, tumor operation, and the lung operation. But I think currently the residual tumor here right now is seems to be only liver and the lung, right? Currently, the residual tumor now we can not the peritoneal abdominal tumor has been removed, right? So the residual tumor right now is liver at 7, 8, and also I think maybe 7 or 5. Yeah, both lung metastasis. Yeah, yes. So my suggestion is for the liver metastasis, you can find a liver surgeon. Is it possible? Or if you have a radiologist, you can do the CT tumor operation for you, for the patients. Yes, I think liver operation and the lung operation can be done in differentiation. Yes, for example, you can do the one lung first, and the other lung next, and liver. Yes, you can do separate in separate session. But my suggestion is that the liver nodule seems to be almost 2 or 3 centimeters. And for the hepatic metastasis, actually the real tumor extension is 10. It's much more than they have been defined PET scan. The actual size is larger than your expectation because the metastasis has certain margin. You have to cover certain margin. So I think for 2 centimeters, one single probe RFA is not enough. Maybe you need 2 or 3 probe RFA to operation to create a larger operation zone to cover the tumor. Yes, but that's my suggestion. I think one probe RFA is not enough to create a septic zone to cover the tumor margin. Otherwise, if you have a microwave operation can create a much larger tumor operation zone than RFA. So microwave ablation is indicating this case because it's nearly 3 centimeters, 2 or nearly 3 centimeters. So either you find the microwave ablation for it, or you find 2 or 3 probes simultaneously RFA probe for this. Yes, to create a successful zone of this tumor. And for those lung metastasis, you can do it with RFA, with RFA probe. That's okay, because the setting margin for the lung metastasis is not so important.
Thank you, Dr. Huang. I will talk little about the case 1 presentation case 1. I think your case 1 do an excellent job for this patient. You do a 2-step lobectomy for the bilateral liver nodule. I think you do an excellent job. I think the case 1 maybe from my point of view, I'm the radiation oncologist. I very appreciate your presentation case about the case one. About short comment about the case two. Previously, our Dr. Zhang and Dr. Huang make a very practical and very good suggestion. You may consider for the case two, because I also think the case two is you do an excellent job. We can see from 2017 to now 2022, people still alive. So you do a lot of work, a lot of good work. From my radiation oncology point of view, because it is for the lung or for the liver is very sensitive for the radiation damage. So the radiation may be put the second step, not for the first step. When you first you can consider resection or RFA. However, for the liver tumor, if the fail after RFA, oligo mass of the liver, you can also consider for the local ablative rate by the radiation therapy ablative. All belong to the local therapy. However, for this case, I don't suggest any radiation now. You may consider any for the lung nodule, for the repeated RFA,
Yes.
for the liver tumor. This is my suggestion. Thank you for presenting two very successful, two wonderful cases for us. Thank you.
Thank you for your suggestion. Yes. Do you have any question? Suggestion for this?
Các bạn có hỏi gì không?
Dr. Huy.
Tôi ok với cả cái phương án điều trị của mình.
And Dr. Khánh, yes, Dr. Khánh, have one question about AEIT. I can speak by English, so I just speak by Vietnamese. Nghĩa là cái miễn dịch tự thân này là chỗ của thầy Văn ở bên trường đại học Y, là cái người ta sẽ lấy toàn bộ cái tế bào miễn dịch của người đấy, người ta ra nuôi cấy ra một nhóm tế bào nào đấy, sau đấy thì người ta tiêm quay trở lại vào cơ thể mình là được 10 tỷ hay mấy tỷ tế bào gì đấy, và nó chỉ hiện tại Việt Nam thì nó ứng dụng ở ở 5 cái bệnh lý: ung thư gan này, ung thư tụy này, ung thư đại trực tràng này, ung thư vú vĩ, ung thư gì đấy, nghĩa là được thực hiện ở đấy mà khá là đắt tiền, mất khoảng 2-300 triệu.
Nó kiểu tế bào gốc đúng không?
Vâng, đúng rồi, kiểu đấy mà miễn dịch tự thân. Khởi đầu đại học Y hiện tại giờ thì ở Vmec có này, ở trong miền Nam cũng có, hiện tại như thế. Anh Thịnh và thầy Ban được làm chứng minh này.
Nó đã truyền đạt cái ngạc nhiên. Cái sẽ mũ sau rồi nó hiện ra.
Vâng, đây là lấy hẳn cái tế bào miễn dịch của cơ thể mình, còn cụ thể thế nào thì em không nắm rõ được.
Cái hỏi cái đấy là có kỹ thuật đấy không?
In Taiwan, do you have AEIT? Sorry. In Taiwan,
Sorry, would you please
Yes.
speak again? Thank you.
In Taiwan, do you have AEIT, like, you know?
some patients, if they have commercial insurance reimbursement, they may visit a local clinic for this treatment. But in our national insurance, we do not provide this treatment.
Chàng có đi được không? Em không nghe được. So you can you repeat?
Oh, and in our national insurance, this treatment was not provided.
Yes, I know.
But some patients, they may seek help for this kind of treatment in a local clinic, and they have to pay by themselves or by commercial insurance.
Yeah, okay, thank you. Ở bên họ thì bảo hiểm người ta không thanh toán cho cái phần này, cho nên là chỉ một vài những bệnh nhân người ta có thể thực hiện cái kỹ thuật này thôi. Bệnh nhân họ thank you for your attention, and now we can finish the reference. Thank you.
Thank you.
Thank you.
See you again.
See you.
Bye bye. See you.
I will-
Rồi.